Dear chair and dear audience, let me introduce my PhD thesis, which is Risk Factors and Therapeutic Approach of Medication-Related Osteonecrosis of the Jaw. Bone cancer patients face a life versus jaw dilemma where treatment may extend their life, but it can lead to the loss of the jaw. Clinicians need clarity whether a combination of anti-resorptive and anti-angiogenic therapy truly delivers optimal efficacy while maintaining acceptable safety profile. In our systematic review and meta-analysis, we found that combination therapy does not significantly improve overall and progression-free survival, but it 4 times increases the risk of medication-related osteonecrosis of the jaw. Therefore, clinicians should reconsider the cost-benefit ratio of combination therapy before administering it. My name is Sára Borbála Szabó. I'm an oral surgery resident and a first-year PhD student. My supervisors are Réka Fazekas and Kruzsina Kis. Our vision is prolonged survival and improve quality of life in patients receiving bone-modifying agents therapy, and our mission is to estimate the risk and rate of medication-related osteonecrosis of the jaw in patients receiving bone-modifying agents therapy. We have 2 specific goals. We started both of them last autumn. The title of our first project is Investigating the Efficacy and Safety of Anti-Angiogenic and Anti-Resorptive Treatments in Bone Cancer Patients. A little bit about the background. About 2 million new patients were diagnosed with malignancies in the USA in 2024. With the prolonged survival of these patients, bone metastases frequently occur. These patients have 2 types of treatment options. The first one is anti-resorptive drugs. They prevent and treat skeletal-related events like pathological fractures, bone pain, and hypercalcemia. On the other hand, they have anti-angiogenic drugs. They block the growth of blood vessels that support tumor growth. As I'm training to become an oral surgeon, I'm concerned about the oral complication caused by these drugs, which is medication-related osteonecrosis of the jaw. This is a severe, painful condition decreasing the patient's quality of life, with an incidence from about 1 to 10% in patients previously exposed to anti-resorptive drugs. But with the addition of anti-angiogenic drugs, this percentage increases. However, there is a lack of information in the literature regarding the exact incidence of this condition after combination therapy. Therefore, our aim is to reach a definitive conclusion on the efficacy and safety of these combined treatments in comparison with the separate administration. Our clinical question is, does combination of anti-angiogenic and anti-resorptive therapies increase the efficacy without enhancing the side effect profile in bone cancer patients? We use the PICO framework. Our hypothesis is anti-resorptive and anti-angiogenic therapy in combination improves the overall survival and does not cause more side effects. Our clinical and research implication is better survival and improved quality of life in bone cancer patients. We conducted our systematic search in 5 databases, and we narrowed it down to 13 articles with my co-investigator. Let me present my first figure. This plot refers to the risk ratios of medication, to our most important safety outcome, which is medication-related osteonecrosis of the jaw. We can assess the effect of combination and monotherapy in bone cancer patients. We are reporting risk ratios. A ratio greater than 1 means that pneumonia appears at a higher rate in combination therapy, while a risk ratio lower than 1, it means that it appears at a lower rate within the same group. We compared the combination of anti-resorptive and anti-angiogenic therapies versus the monotherapies alone, and we did subgrouping based on these. We included 11 articles, about 4,000 patients, mainly retrospective cohort studies and some RCTs. The heterogeneity is moderately high. It is 61%. The reason for this is they use different kind of cancers, different monotherapy like drug type, dosage, frequency, and duration of time. The risk ratio is 3.95, which means that pneumonia appears at a 4 times higher rate in combination therapy compared to the control group, which is monotherapy alone. This is a clinically relevant change with a mathematical significance, so clinicians should reconsider using the combination therapy. Our second figure is about our most important efficacy outcome, which is overall survival. Overall survival is a gold standard endpoint in clinical trials to evaluate how effective a treatment is. We are reporting hazard ratios derived from survival analysis. A ratio greater than 1 indicates that there is a higher risk of mortality at any given time with the combination therapy, and the hazard ratio lower than 1 indicates that there is a lower risk of mortality within the same group. Subgroups were created based on cancer type. We did the subgroups for metastatic renal cell carcinoma and non-small cell lung cancer. We included about 6 studies with 4,000 patients. We included mainly retrospective cohort studies and 1 prospective RCT. The heterogeneity is really high in the first subgroup, which is 80%. The reason for this is they use different type of monotherapy, and there was a varying length of the study periods. And in the second subgroup, the heterogeneity is 0, which indicates that these studies are highly consistent. The risk ratio of the first subgroup is 0.71, meaning that in the combination therapy, there is a 29% lower risk of death compared to the monotherapy alone. And in the second subgroup, the hazard ratio is 0.30, which indicates almost 70% lower risk in this subgroup. And these two are clinical relevant differences. However, it is significant only in the second subgroup from a mathematical point of view. So patients in both of the subgroup receiving combination therapy, we found that it improves the survival and it is preferable to monotherapy. Our first project is now at the writing stage of the manuscript. The strength of our study is assessment of safety of combined anti-angiogenic and anti-resorptive treatments, and also the exploration of the effects of subgroups on the efficacy of combined anti-angiogenic and anti-resorptive treatments. Our limitation is small sample size, moderate to high heterogeneity between studies, and also the data inavailability limits the depth of our analysis. In conclusion, for patients with metastatic renal cell carcinoma or non-small cell lung cancer, combination of anti-angiogenic and anti-resorptive therapies increase survival and may delay disease progression, but increases the incidence of medication-related osteonecrosis of the jaw by nearly 4-fold. Our first implication for practice is combination therapy improves survival and quality of life in bone cancer patients, and clinicians should ensure that appropriate oral prophylaxis is used and that patients are monitored when these medications are used in combination. And our most important implication for research is researchers may need to perform subgroup analysis or use a random effects model to account for the high heterogeneity. The title of our second project is Investigating the Resolution of Medication-Related Osteonecrosis of the Jaw, and this is the registry analysis project. A little bit about the background. The management of this condition is based on stages. There are 2 main ways, the conservative and the surgical way. However, almost 20% of patients remain with persistent symptoms. So our aim is early diagnosis and control of the course of the condition. Our clinical question is, what are the optimal treatment paradigms in different stages of this condition? We use the PICO framework, and we have 2 hypotheses. The first one is surgical treatment in combination with medical therapy offers more predictable results than non-surgical therapy alone in all disease stages. And our second hypothesis is the rate of resolution of this condition is related to the severity and stage of this condition. Our clinical and research implication is characterizing treatment patterns for medication-related osteonecrosis of the jaw to improve the patient's quality of life. Now we are at the PICAB license phase, and we are developing the eCRF user guide. To summarize our 2 main projects, we are planning to submit the first one this September and the second in 2027. Research means that you don't know but are willing to find out. Thank you for your kind attention.
Thank you very much, and I would like to ask the audience first. So congratulations for your presentation. It's not a question, but a remark. So if you can flip back to the second figure of the first project. Here. So if you are looking at the prediction interval of the first subgroup, the confidence interval is very wide. So it doesn't help. In my opinion, I think that it should be removed from there because it doesn't. I mean, it shows that future studies would be located on either the left side or the right side of the forest plot. So this is my.
Thank you for your recommendation. We will remove it. Thank you.
It's up to you, of course, but
yes,
usually if you
see what you mean.
Usually, if you have like less than 6, 7 studies, the prediction interval is not relevant.
Thank you.
Congrats again.
Thank you.
Thank you for your wonderful presentation. I would like to ask you, in your first study, were there any studies that they considered preventive measures, or have you seen, regarding the osteonecrosis of the jaw?
Yes, the most important preventive measure is that before administering these therapies, the clinicians, the oncologists, maybe the hematologists, they have to send these patients to a dentist or to an oral surgeon, and they extract all of the bad prognosis that have bad prognosis, because when you have inflammation in the mouth, this can trigger osteonecrosis of the jaw when they start the treatment. So it is really important before starting the treatment, the clinicians have to know about this condition, and they have to send these patients to the dentist or to an oral surgeon.
Thank you.
Congratulations. I was just wondering, did any of the articles mention anything about the oral effects of these medications? Or could they potentially worsen the patient's oral status after the administration of these drugs? So could it just dramatically worsen even though it was not predictable, so they couldn't have removed the teeth that were at risk?
Yes, thank you for your question. Yes, in some articles they wrote about the oral and systematic risk factors for this condition, and in the oral systematic factors they always wrote down that periodontal disease is also a risk factor. So when patients have a lot of calculus, a lot of inflammation, it can also trigger this condition. And I have seen this also in my practice, that we extracted almost all of the bad tooth, but the patient had periodontal disease, and he was at a life-threatening stage, so he had to start the combination therapy, and she developed this condition, unfortunately.
Okay, I understand. Thank you.
Yes, thank you.
Just going back to what just previously mentioned about this plot, that if you see the first carcinoma, then the two studies are correct because they have events. For the third and fourth, there are no events.
Yes,
am I right?
This is one of the limitation of our systematic review meta-analysis, that we wrote to the authors and they didn't respond because we wanted to know the events, and they didn't include it in the article, but we talked with the statistician and he said that
then you have to choose, because at the end you concluded that regardless what carcinoma the patient has, you have to be careful and you have to advise to add the combination therapy. However, based on this figure, I would selectly concluded that for the second carcinoma it's good, for the first one is not.
Yes.
But I would make, this is one alternative, but there's a second one, that you rerun the first analysis just including the two studies which clearly has events, because if it has no events, I think that for the wide prediction interval. And say that we rerun this analysis only included the two one, and then I think they will be significant.
Yes, thank you for your recommendation. We will talk about it with my supervisors. Thank you.